Hey friends, welcome to another Transforming Chaplaincy webinar. It's so good to have you among us, and thank you for taking time out of your busy day to join us for today's presentation. I'm going to pull open some slides here and do some introductions to Transforming Chaplaincy. If you've never been with us before for a webinar, we are glad that you are here. And Transforming Chaplaincy seeks to be all about the business of what it means to advance spiritual care through research. So if you're here for why do cancer patients of Dharmic religions rarely ask for a chaplain, you are in the right place. And Brown Jones, who's the person on the right, will introduce these folks in a minute. We are online, but we'd love to see you in person and come to Chicago. In just under a month, we are hosting, I can't remember, like the 7th annual Chaplaincy Research Summer Institute. So if you have a smartphone and you want to get a QR code, if you're interested, please consider taking a look at the information that's available through there and then potentially submit an application to join Transforming Chaplaincy in Chicago. This opportunity is not for a week, it's actually for about 9 months, from September to May. This has also been going on for several years, this spiritual care leadership and management program, and please consider being a part of that. The people who are there on the screen are a part of presenting for their capstone. So it's almost a year-long program where you invest in this process. And if you want to learn more, again, use that QR code to check that out. I want to mention that we just recently hosted the first ever inaugural Healthcare Chaplaincy State of the Science in Bloomington, Minnesota. And I tried to emphasize how we say it in Minnesota. So if you were there, thanks for being a part of that event. It was something to remember. And Transforming Chaplaincy exists because of the goodness of many people, whether they come as grants or people who are generous to us. So if you are interested in supporting the cause, there's a QR code there for that as well. We would love to have you join us online. We have something called our research networks. There are 9 of them, and many of them were able to join us in Bloomington and was able to capture a photo. The one that I would love to introduce is the convener of our cancer care network. That is Bronwyn. Bronwyn, since 2014, has served as the lead cancer center chaplain at Cedars-Sinai, embedded in the patient and family support program. She is board certified by the APC, endorsed by the Humanist Society, and received her master's degree in theology from Loyola Marymount University. And prior to her chaplaincy career, Braun was an orchestral clarinetist and worked as a film composer in Los Angeles. I'd love to hear a little bit more about that. Receiving an Emmy for her original score for American Public Television's Your Turn to Care series. Brahman, it's great to have you as a convener. I'm going to turn it over to you.
Thanks so much for that introduction, Paul. I'm really delighted to be able to introduce to you Dr. Rushil Patel. I actually first heard of him back in 2020 because one of our fabulous supportive care doctors in the team emailed me Dr. Patel's top 10 things palliative care clinicians should know about caring for Hindus. That came out of the Journal of Palliative Medicine. So I heard about Dr. Patel way back then, and now I get to introduce him to today's webinar. So how come, we don't get enough referrals for Dharmic religious patients, right? Anyway, so Dr. Rushil Patel is an assistant professor of medicine at the O'Neill Cancer Center, University of Alabama at Birmingham, where he cares for adults in sickle cell disease and hematologic disorders. He completed medical training at University of North Carolina in Chapel Hill, followed by internal medicine residency at Cone Health, and fellowships in hospice and palliative care medicine at Memorial Sloane Kettering, and in hematology oncology at the Atrium Health Levine Cancer Institute. His research focuses on developing culturally concordant models of palliative care. And so then, to respond to Dr. Patel's presentation, we have Venerable Jiyun Kai. Actually, Bhikkhuni, Dr. Jiyun Kai. Bhikkhuni is a title for somebody who's been fully ordained in her tradition. So Venerable Jiyun Kai has one of her names. That's her official name. And her Dharmic name is Venerable Long Yun She. She's been fully ordained Buddhist nun in the Zen Buddhist tradition for 32 years. Yun is the abbess of the American Bodhi Sea Buddhist Association. Yun serves as an ICU and oncology interfaith chaplain at Stanford Healthcare. She's board certified palliative care chaplain and a grief counselor. And I also want to mention that I met her in 2015 when she took one summer CP unit with us here at Cedar Sinai at Cancer Center. Okay, lovely. Welcome to you both. I'm going to turn my camera off now. I'll hand it over to you, Dr. Patel.
Great. It's good to see the turnout and happy to be here. I'm trying to make sure my screen. So I'm in front of 3 screens, but they're not all connected to the same computer. So hopefully it's not something that I regret. You all can see the slides?
It looks great.
All right, awesome. So I kind of wanted to take us through, for this community of individuals, Dharmic religions, people who identify with cancer and sort of their preferences in spiritual care, and how I even came to think of that, because as a physician, this is not sort of the thing I was writing about in medical school essays, but certainly it's something that continues to drive me both professionally as well as personally. And so I was hoping today, as we kind of go through, to think through sort of what concordant care looks like for people of these communities and how it requires the integration of their beliefs and values. And to start us off with, I wanted to look at sort of the sociocultural context here in the United States to give us a bit of a backdrop, then the actual data that we were able to collect, and then end with sort of a positive lift, if you will, as to what are some solutions that can come out of this as we think through the future. I will also say, and I'm open to feedback, that most of these lectures, this presentation, I do with the physician audience. So I did leverage AI to help me identify what parts I can overlook, what parts would be sort of basic knowledge to somebody who is first in chaplaincy. So, like I said, I'm open to hearing what folks say with regards to some of the background information. So to take us through, I'll start off with context, and I think it's important to take a note of, why is it that we are thinking about these communities, Dharmic religions. So first and foremost, when we think about the world and splice it up into a world pie graph, if you will, there's a number of folks who don't identify with a formal religious tradition, but taking those apart, roughly a third identify. I'm trying to move this on the screen. Roughly a third identifies Christian. There's another quarter-ish who identify as Muslim or with Islam, and then remaining of the Abrahamic family, 0.2% identify as Jewish. And then there's another quarter of folks who identify with these family of 4 traditions that we will collectively refer to as the Dharmic religions. This includes Hinduism, Buddhism, Sikhism, and Jainism. It's important to note here that it's beyond the scope of this talk to talk about all the differences within these traditions, but it is important to note that they all sort of share very similar basic beliefs and tenets that shape serious illness and especially cancer diagnosis. And that's why we're sort of looking at them collectively, and then other religious traditions that sort of fall in between after that. And going back to sort of some of the shared beliefs, there's also, I'm being very careful, with not confusing religion and culture, but there's also cultural norms that are sort of similar to these traditions that are found in the South Asian and East Asian context, which involve caregiving, which again shape sort of palliative care preferences as a whole, as well as, the folks that we see in the hospital. And though, the Pew Research Group, they put out these analyses looking at religion and public society. And I haven't seen I know they've put out recent data, but they have not done recent projections. But from data that was from the projections 10 years ago, and some of the recent analyses, the portion of the pie that identifies as minorities within the country is expected to grow, largely driven by immigration. And we can see, in this analysis, even though again it's 10 years old, that they're expecting to share in the foreseeable future, or at least within our lifetimes, hopefully my lifetime, that these numbers are growing. And it sort of maps, I will say, with what we are seeing across different parts of the U.S. Now, again, there's no great. The hardest part, I think, for a talk like this is to find background information, just because it's sort of a hodgepodge. People don't really collect great religious data on religious affiliation. But there was one survey that was done amongst Indian Americans across the US, and this was back in 2020. Notice the pockets of people, again, the bigger the circle, the more individuals that participate in the study. And some of the questions that they asked identified with religious identification. And a little over half of the people who are participating in the study did identify as Hindu. And we also know that there's a good share of from Asia, large share of Buddhism within the Chinese context, and that represents a large group of Asian immigrants to the US. So all things considered, the share of these faiths is expected to be growing in the foreseeable decades ahead. And so that's what brings us now to kind of think about, as we are trying to figure out different tailored models of care, how well do these groups sort of fit into what our current system has to offer? And so this is sort of what perked my interest in when I was in palliative care fellowship training at Memorial Sloane Kettering, because up until that point in my career, I had never once sort of thought about religion. But working in palliative care with an interdisciplinary team, with having a chaplain on staff, really that's when we began to, at least for me, I start looking at, oh, look, religion is something that's actually documented on the chart here. And then on top of that, to see different traditions that were being documented, and myself as a Hindu, it sort of came to me, or I thought about, like, how do people within my community and similar communities perceive the role of a chaplain in spiritual care. I mean, I saw all the great work that chaplains did at MSK, and that we would have our interdisciplinary rounds, but it wasn't until then that I didn't think about how this actually presented itself in real world settings. So in this analysis, so after I did my 1 year of fellowship training, did a year as a research fellow, what we wanted to do was to look at spiritual care delivery to people identified with these 4 traditions. And we had a 2-part approach. So first part was we looked backwards, and over a 5-year period, which is now we all know is the pre-pandemic period. I did not know that at the time going into this. And we wanted to see, one, spiritual screening, how many people were screening for unmet needs on admission. And I'll go a little bit more into that. 2, how often people were actually seeing a chaplain. And then 3, looking at in the chaplaincy documentation, what are the different ritual care needs that were being identified. And then some of the secondary endpoints we looked at were palliative care utilization, since spiritual care, part of spiritual care falls within the purview of palliative care physician or clinician. And then finally, end of life care outcomes, which are widely known, or these are widely accepted measures within the cancer outcomes community. For the purposes of this presentation, I'm really focusing on the first 3, and if we have time, we can go into the last 2, but really going to focus on the first 3 quantitative endpoints. So that was part 1. Then part 2, we looked at people who were being admitted. Now, 2020 was obviously, it's an understatement, very momentous year. And in the midst of the pandemic starting and being in New York City, had the opportunity to still conduct interviews with patients, initially in person, and then it became over Zoom, or over phone with Zoom running in the background. But to really understand hospitalized patients who identify with these traditions about, how does religion and spirituality shape their illness, their perceptions of spiritual care. And really, I'm going to be focusing on this perception of spiritual care in this presentation today. And then also to interview the chaplains. There were 11 chaplains, 10 chaplains. We included 1 chaplaincy president as well, and to explore their experiences. And it was very interesting just because they had different perspectives, as we'll get into a little bit later with going through all of this. So for starters, taking kind of the 360-degree bird's eye view, who all was in the first part, the retrospective looking backwards cohort. Oh, before I jump to that, just as baseline, in case everyone may not be familiar with the Rush protocol, developed at Rush University by some folks who I actually see in the audience, is really meant to kind of standardized way to screen for unmet spiritual care needs. So, the first set of questions you can see on the screen is religion spiritual important to you as you cope with your illness, yes or no, which then generates 2 separate sets of questions. And where you see the star is the definition of what someone who might have an unmet spiritual need would respond to. And if people at the hospital, answered in one of these two conditions, there was an automatic referral that was sent for a chaplain to visit someone. People could still be referred by a clinician, or a patient could request a referral to a chaplain, but this was an automatic system that was set up to just sort of catch people up front who might have unmet spiritual care needs on admission. And then the other thing for definitions, the things we were looking at the chaplaincy documentation, these are from the National Comprehensive Cancer Network. They have a whole set of guidelines on different aspects of cancer care, one of which is psychosocial distress. And you can see these are the different items that we were looking for specifically, myself as well as a chaplaincy colleague, just to make sure we were capturing these needs and documentation. So now I jump into the overall cohort. And so we actually were able to, because of the volume of people that are seen at Memorial Sloane Kettering, it ended up being a total of 55,000 patients. Again, 360 view. Most of whom identified as Christian, followed by Jewish. There was these large cohorts of none, unknown, and other. And we really struggled to figure out kind of the known, none, and unknown from my colleagues' experience on the chaplaincy side. Sometimes things were not captured at registration. Sometimes people didn't feel comfortable disclosing their religious affiliation. All the analyses I'm going to show on subsequent slides, we did adjust for keeping these people in these categories as well as removing them altogether, and it didn't change the results that we're about to go through together. So 55,000 patients altogether identified that were hospitalized over this 5-year period, of which 2%, a little over 1,000, were of any one of 4 Dharmic religions, with most of them, like 50 to close to 60%, being Hindu. We did encounter some folks who identified with multiple traditions, and so within the Dharmic religion fold. And so we also included them here as a separate category, just to point that out. Then when we started looking at actual screening, using the Rush protocol, trying to identify the proportion of those who had unmet needs, we actually didn't see a significant difference between the two. There was slightly more on the non-Dharmic religions, NDR for abbreviation, compared to Dharmic religions, but not a significant difference. Then when we actually bore down to who was seen by a chaplain, this is where it started to get interesting, in that there was a significant difference when you have a sample of 55,000 people. A 5% absolute difference was coming out to being met the threshold for statistical significance. And then that begs the question, is there another variable underlying all this that might account for this 5% point difference? Now, why is it that somebody who's admitted of Dharmic religion less, or why are there less chaplaincy visits for that group than the other? And so we looked, through the literature and some of those other variables, and we did multivariate analysis where we tried to control for those factors. And so this next slide, which has the table here, everything that we looked at: age, religion, race, how long somebody was in the hospital, religious affiliation, and obviously how sick somebody was. And the 3 that are highlighted in red, those ended up being independent predictors for whether or not somebody saw a chaplain. And so again, the longer somebody was there, they had a higher odds. How sick someone was, and this was defined by whether or not they died in the hospital, went to the ICU, or went home with hospice care, higher likelihood. And interestingly, if somebody was not of a Dharmic religion, again, independently associated with seeing a chaplain or not. So that was, again, something going into this, not expecting to find, but something we ended up finding. When we looked at the notes that the chaplains had compiled for these individuals, so all of the people who were seen by a chaplain, it was about 368 patients in the Dharmic religions category, about 100 of them who actually had notes that had enough prose to be able to parse out different needs. These are the top 5 that were coming out based on the NCCN definition that I'd showed earlier. Ritual needs were by far the most common, and these include anything from request for prayer, scripture even, or trying to meet with somebody from one's community, own faith community, to try and complete some part of ritual care that the hospital couldn't otherwise offer. I will say, looking through all the documentation, it was never clear whether or not those requests were acknowledged, but I think there's more to say on that when we turn to sort of looking at the actual interviews and the insights people shared on the interviews. So on that point, this is a good way to segue into the interviews themselves. So again, this was interrupted by the pandemic, but thankfully we were still able to complete a good number of interviews. So I was able to interview 22 patients, majority of whom were Hindu. There were 2 that identified as Sikh, but the rest, the 19 patients identified as Hindu. And then the chaplains who served them in the hospital, majority of whom identified with the Christian tradition, also 2 that identify as Muslim, 2 identify with the Jewish tradition. And the important thing here to note is that nobody was of the 4 Dharmic religions, so it offered an interesting places to see where perspectives converged as well as where they diverged. I will also add that most of the people in the patient group, a little over 65% were women. Most had emigrated from India, 82%, and they had been living in the U.S. with a median number of time in the U.S. of 30 years. And most also had a solid tumor diagnosis, although 2 were diagnosed with concern for solid tumor and ended up not actually having cancer. That was not known at the time in the interview. On the chaplain side, again, also a little over half identified as women, 55%, and most median time of experience was 10 years within the chaplaincy group as well. In terms of some of the major themes that came out from the interviews themselves, so here it's going to get kind of text heavy because I didn't know what better way to put it than to put people's words. So on the left side, I'll put the patients, what patients had to say. On the right side will be what chaplains had to say. And so I saw this a lot in the interviews, quotes that sort of reflected multiple iterations of this over and over, where people just didn't understand when you use the word what chaplain is, they didn't know what that was. And then what spiritual care was, they didn't know what that was as well. And so on both ends of the spectrum, people were confused when I presented those terms. And then on the chaplaincy side, this is something that several individuals had picked up on. One chaplain mentioned that unless somebody has had sort of a secular education in the Western world, these terms, spiritual care and chaplaincy, are not, familiar, they're not things, concepts that individuals are familiar with. One other individual mentioned this perception that clergy are not very central to people who fall within these traditions, and then adding more that whereas in the Western faiths, the clergy is more present in sort of day-to-day activities and giving guidance, that we don't see that as much with Eastern traditions, at least from the purview of this individual. But for the most part, this was a theme that I saw a lot on the patient side for sure. Now, number 2, there were perceptions of discordance, faith discordance, that were coming up with regards to people being able to see chaplains. So, several individuals remarked something along the lines of, I don't see any Hindu person here. It wouldn't look nice to them, if they were to engage in their different rituals and practices. In the hospital, these were shared rooms outside of the transplant floor where there's an infectious risk. So this was a consideration I had never really thought about. When you're sharing a room, how would the other person feel when you're practicing a faith that might be unfamiliar to the person on the other side of the room? And the other thing folks mentioned was just in general, just a lacking kind of awareness or knowledge of the Hindu faith or Hindu tradition, and just not knowing, expecting that people really wouldn't know a lot about their own belief system. On the chaplain side, it was sort of as one person remarked here, people may say no needs, but if you were to ask, it's sort of like a thank you, but no thank you sort of sentiment that they felt was being expressed. And so people were being polite, but just sort of saying, we're not interested, and turning the chaplain away. In terms of, oh, I forgot one other thing. And one other person added on that note of just whether or not is this because they see me as an outsider to their culture that they're not sort of inviting me into the room? That was a question that was raised as well. At the same time, there were definitely spiritual care needs, and some people, came into the hospital. Most people, or I was going to say, most of the patients, they found ways to address their needs without the help of chaplains. So some people just had an individual practice, like at this individual who had their own prayer ritual, they knew what to do, and didn't, make it a big deal. They don't want other people to know about it. This is something that I do. I'm just going to figure out a way to get it done, so I don't need any accommodations. Similarly, this other patient identified, or at least reflected and said that it's not something I expect when I'm in the hospital. And so I don't think of it as something that I would even request. And then another person remarked how they had family members who were also helping to tend to some of these needs. So they're already getting their needs met. Why need to ask someone else for it? And then what was also curious was when some chaplains had mentioned that being turned away, there was other individuals who mentioned that if there was a need, they were not turned away. And as evidenced by this quote here, where I haven't been declined because they didn't know what a chaplain was. And so there are certain situations that did arise where people did turn to a chaplain for help. But altogether, when I sort of put the insights as well as the numbers and and some of these themes that kind of came out of this, quantitatively as well as the insights shared by folks, it did suggest that there was at least an inequity in delivery of spiritual care, which I can't say, and as I'll go into, it's any fault of any individual chaplain. I think it's just from looking at sort of the Institute of Medicine and how they define disparity, and we've tried to move away from that language to inequity, which is a correctable gap in care. We looked at the fact that there was not really a significant difference in unmet need, but rather what I was hoping to kind of put context here is to kind of look at how that system is operating. Certainly, there were one or two quotes that mentioned certain sort of like perceptions and stereotypes, but I really wanted to focus in on sort of the system aspect of things and where we can think of solutions and sort of try and move forward to kind of get people the help that they need. And so there was actually a professor here at the University of Alabama, and Michael Altman is his name. He's written this book. This is something, again, not knowing, going into this work to think that would offer a sort of a historical context. But, it's really interesting as I was reading this book, and I don't have any background in religious studies, but he goes through sort of how religion, even as a construct, was presented, in sort of the late in the age of colonialism, and how there's sort of this taxonomy of different religions, and it's nice to know that we no longer use the word like heathens to describe people who don't fall within the Abrahamic family, but it was sort of within this kind of grouping, if you will, at these different terms of like Hinduism, Buddhism, Sikhism, Jainism would sort of evolve from. But it's not enough to just point to the religious scholars, because even the people who designed the U.S. Census about 100 years ago, and as you can see illustrated in this congressional report, the word Hindu on one hand was used as a religious term, but then was also used in sort of a racial sense as well. And then in this book, Professor Altman also goes into, after sort of the 50s and 60s, with the rise of the counterculture and everything, and how this construct of spirituality was sort of developed, and how there was a lot of concepts that were put forward that originated within sort of the Buddhist or Hindu landscape, if you will, but were then sort of taken away from the original kind of cultural context and repackaged in this term of spirituality. So some of seeing what was being said in the interviews and things, and reading this book, it's sort of, in my mind, it at least offered a parallel and sort of an explanation. And I do promise, like as I said, I wanted to end on sort of bright note. What is the path forward? Knowing this is the history and this is what we're seeing. One is that came up in the interviews was to just hire more people who identify with Dharmic religions as chaplains. This individual mentioned having a Panditji who would then be able to come and basically chant mantra with somebody while they're at their low point in their illness, and acting as a guide. Another woman here, she mentioned how having somebody with a Hindu background, there's certain concepts that wouldn't need to be explained because they would already know these concepts. So, if I'm trying to connect with somebody, it'd be nice for us to have shared understanding of basic concepts. And I love this quote for one of the chaplains that I enjoyed working with, and just said it very colorfully that this is, if you have somebody who identifies with these traditions as a colleague, you can share the stupid questions that you wouldn't feel comfortable asking anyone else in the privacy of the office. So that came out on both sets of interviews. Second, that also came out was, it kind of goes hand in hand, is to improve training. And this is actually from one of the chaplains themselves mentioning how, they think back to their training and how they have all these different case studies. When these case studies have been reviewed, there's not really a representative from any of these traditions to sort of critique someone's interpretation of what's going on. And so having more people involved in the education process of training a chaplain was something that came out from on the chaplain side specifically. And then finally, both sides, again, patients and chaplains mentioned having community volunteers involved in investing. The hospital should invest in that, but that was not without barriers. The chaplains mentioned that one, having a limited network of folks, when you're trying to pull people from a small community, they may know people in the community and they may not want those people to be involved in their care. And so there's that issue, being able to find folks who are at least competent in the basic things that a chaplain is able to do, and then figuring out who does what and how do you partner and align with that within a healthcare system. So that was something that came up. Then obviously in New York City, you cannot talk about bringing people in without talking about parking. So the logistics of getting people into the hospital, sometimes there was a language issue. The chaplains would try to reach out to folks, but the person who picked up the phone may not always have the most understandable, or may not be able to understand what is actually being asked. And then, as I mentioned, privacy was a important consideration that came up over and over, or that did come up in some of the interviews. Altogether, with any kind of data analysis, do have to put out the limitations of, so I'm not overreaching with what we've interpreted. This is only one center where we're able to collect this data. It lacks, in scientific terms, the ability to generalize to other centers. At the same time, I will say New York City is, if you go back to that map at the beginning, one of the largest enclaves of people who identify with these traditions. So it does beg the question, if we're struggling in a place where you already have as many, a huge concentration, what does that look like in other parts of the country, where we may not have the huge numbers to replicate the same quantitative findings. And we are doing currently in Charlotte, interviewing patients as well as caregivers who identify as Hindu to see if the findings are matching with what we found in New York City. Second, whenever you look backwards and chart data, there's always the chance that things are missing, things are not accurate. And we did the best we could with our methodological constraints to make sure that the findings didn't change if we took the people who said they identify with the religion or who had missing data. That didn't change our findings. And then finally, we talk about Dharmic religions, and we talk about core traditions. I would be missed if I didn't mention that the number of Sikh as well as Jain adults were very, very limited in this analysis. When in the paper itself, when you look at sort of the population estimates, it does track though with proportionally speaking how many Sikh and Jain one would expect with a sample of this size. But it's certainly worth study for future projects down the road. Altogether, I think wrapping up here, putting one is the rationale for why we're looking at this is these communities are growing across the U.S. The evidence here presented does suggest that there's inequity, delivery of spiritual care, and of course, trying to staff folks, improve training, and leverage the community is something that can also be worked upon. Lastly, wanted to acknowledge all the people that participate in the interviews, many of whom, 2/3 of whom, never saw me face to face, yet they opened up about intimate things over phone during the COVID pandemic. All the people have helped kind of put the findings together, as well as review the findings once we had the findings, And then finally, the sources of funding that allowed this work to be possible. On that note, I wanted to turn it over to my colleague, Yoon.
Thank you, Dr. Patel. Thank you so much for your insightful presentation on your study experiencing the chaplaincy utilization among this hospitalized adult of Dharmic religion with cancers. And I can see from your findings revolving a critical gap. So from your research, and I read your papers from your presentation, I can see they show that only 31.6% of Dharmic religion patients utilize chaplaincy services, compared to 36.7% of others. So driven by barrier like the patients, they do not understanding what really chaplain do, and also another reason is a concern about face decoratant care. So this finding also show the ritual care is a primary need, and so the 72%. And the research also suggests a call for more Dharmic religion chaplain and a community partnership for offer more effective services to these Dharmic patients. And for me, I'm a Buddhist nun, and I'm a interfaith chaplain service at Stanford. I also have strong, really feelings, and experience how our Dharmic patient and family members, they really do not know what does chaplain do, and why the hospitals, we have those group of chaplains. So for me, every time when I visit Buddhist patient, Hindu patient, they always ask me, "Hey, Venerable or Master, which temple are you come from?" So even every time I tell them, "Oh, I come from these temples, but right now I am the interfaith chaplain service at hospital," they still very difficult for them to make the connections as a monastic, the role of monastic, and the interfaith chaplain at the hospital. So when I'm doing my follow-up visit, the second visit, the patient says the same thing. "Hey, Master, thank you so much visiting me. You must have very difficult looking for parking, right? Thank you." They always cannot get that sense. I am the part of medical team. Even I really explain for them several times. And also, Dr. Patel, in your same tool, you mentioned about this Dharma, we call DR patient, right? And the chaplain identify face discordance as a barrier to inpatient spiritual care services. So from my clinical experience, many Buddhist, for example, Buddhist patient, right? They really worry that this non-Dharmic chaplain, they do not understand their beliefs. So I'm service in the cancer units. So from my experience, many of the cancer patients, after diagnosis as an aggressive cancer, usually they find their own way to understand and to accept their diagnosis. So one group of patients, they accept their diagnosis from their beliefs. So they think, I believe the Buddha, I believe along I practice, I can be free from this life circle. I can be free from suffering. Then I'm going to have a better next life. I may reborn in the better place, or reborn in the pure land, or attend the Buddhahood. Just following their Buddhist schools. So this is hope. They have strong hope. This hope can lead them make very smoothly peaceful transitions. For this group of Buddhist patients, sometimes they even do not need me as a Buddhist monastic. So one of my cases is there's one 68 years old Buddhist lady. When she was on the deathbed, and the doctor make referral, they said, "Oh, chaplain, you have to come," because the patient is dying, but she refused to use any kind of pain medication. You have to go talk with her. So then I received referral, I presented bedside. So when I entered the room, I saw a lady lay in the bed, appear very peacefully. I hold the chanting beads in her hand and keep chanting the name of Buddha. So I presented by side, I introduced myself. And the lady looked at me. She said, "Thank you so much, Master, for coming visit me. Now I'm concentrated on my recitings. I need a blessing from the Buddhas. I want to reborn in the Pure Land. So sorry, Master, this time, at this moment, I cannot talk with you. I cannot distract my mind. I have to practice this moment, very important for me." So in that moment, for this Buddhist patient, they even do not need me, do not need a monastic. This is one of my cases I encountered in my clinical services. Actually, I have more than one case. They do not need me because they practice really diligently, maybe whole their life, especially at the end of life. And also, the theme too, Dr. Patel, you mentioned about, as we mentioned, the patient, they understand their disease maybe through the karma, what they believe in karma. The karma is common belief in these four religions, Dharmic religions. The karma, mean cause and effect. Some patients, they believe the reason they got the cancer disease because the result of negative karma or sin from the last life, from the past life, the previous life. So it's a karmic outbreak. It's a stigma they do not want to share with others. So I encounter many this kind of cancer patient. When I visit them, the family member keep remind me, "It's Master, you can talk with my mom, but just do not talk about cancer. You can talk anything. Don't talk about cancer because that is going to make my mom very, very unhappy, very, very angry, very, my mother will feel very guilty at that moment. Don't talk about cancer." So this patient and at the hospital. But how about in the temples? In the temple, I encounter many cases. We have long-term Buddhist fellows, maybe in the temple 10 years, more than 10 years. And suddenly, one day she disappeared. We make a phone call, nobody pick up the phone. This fellow doesn't come to join the temple activity anymore after 6 months. And the family contact with me. They told me, "Oh, Master, and my mom passed away." I said, "What kind of disease?" She said, "Okay, I can share with you, but please do not share with other community members. My mother passed away by cancers." So this strong stigma always be with the cancer patient and the family members. That's the reason they do not want to share. They don't want to share their disease when the chaplain come to visit. I believe that's one reason they do not really want to talk. They don't want to talk. They don't want to talk about the disease because they feel that's their wrongdoing, from the previous life. So this is my clinical services about this group of peoples. And also, I saw Dr. Patel give wonderful suggestions in this presentation. We call for more dynamic religion chaplains and community partnership. So I also have some experience. So I think educated chaplain, of course, is very important. Educated chaplains includes the Dharmic chaplain provide didactic to our chaplains. So in my case, every year at Stanford, at least I provide didactic once to our CP students. And we discuss how to provide Buddhist supplies to Buddhist patients, and how to chant sutras and mantras. And also we have we also a wonderful resident also make a Buddhist prayer booklet, and it's we feel free to share. We have electronic copies. So every chaplain, we're very familiar with what a Buddhist patient they really need. So when we present at bedside, sometimes very easily to make that inner communication with a patient. And also volunteers, right? The volunteers, we always invite volunteers that come to the hospital, join the volunteer services. We have a twice a year open these trainings. And when the volunteer comes, they come provide services weekly to service the patient, have the same faith background with them. The Buddhist volunteer goes to the Buddhist patient, and Hindu volunteer go to Hindu patient. That's a benefit to our chaplain is after this volunteer build very trust relationship with patient. When the volunteer, they feel the patient need to follow up visit, they make refer to the unit chaplain. Because this volunteer build very close relationship, so make the units, this non-dynamic religion chaplains, very easy to make that spiritual assessment with the patient because already have a volunteer visit and introduce, oh, you have unit chaplain. The chaplain maybe not Buddhist, not Hindu, but they can provide services, effective compassion service to you, and do want to try. So that makes our visit very easy. And also we mentioned about the educate the local community members. So I offer the didactics regularly for our local Buddhist community members. First of all, I invite them come to be our volunteers, join our volunteer trainings. For some members, if they are qualified, also they're interested in our CP trainings, they can become our students. And also, when these committee members, they became patients, they hospitalized in the hospital. They know how to request chaplain visit. Also, they know all chaplain, their interfaith chaplain, also they receive professional trainings. They can provide all services to them. So they learn how to request interfaith chaplain from their unit, even though they are Buddhist, the Hinduism, whatever. And even our unit chaplain is a Christian or have other faith background. So I got a lot of very positive feedback from the committee members. So one of feedback is they told me, Master, we feel really regret not knowing earlier about this hospital chaplain services. If they know earlier, when my husband, he's Buddhist, when he passed away, we will accept unit interfaith chaplain services. So they have no knowledge. So I believe the training is very important for them. Also, we cooperate with the local committee members. So that is some my experience as an interfaith chaplain with a Buddhist faith background in my clinical services. Thank you.
Thank you, Drs. Yoon and Rochelle. Thanks so much. As we transition here to some Q&A that's popped up, Rochelle, I don't know if you have you want to respond to Yoon before we do that. In a way, you don't have to, but I just didn't know if you wanted to have a conversation with one another before we move
No,
that forward.
that was very thoughtful. Commentary that she offered, and I was going to say the point about karma. And again, I'm speaking from sort of like of all these four traditions, Hinduism I'm more familiar with, and I didn't go into this, but was actually curious. Is that a number of the folks who I interviewed, they saw karma from the lens of I'm dealt with this disease and what do I do with it, versus more of sort of the retribution aspect of it, which I think some of the chaplains were expecting when they walked in the room. But I definitely agree with the community needing to educate the community about the role, because I think a lot of people just are not familiar with what this is. And that's something, that's sort of like a future proposal in the works right now, is how can you use the community to bridge the patients with the resources within the system.
I'll just pick up a couple logistics, and then Bronwyn, I'd love to turn it over to you if you'd like, or I can ask the questions. But one is, Yoon, would it be okay if I dropped your work email address into the chat? Some people are interested in the Buddhist resource that you had mentioned. And speaking of resources, Rochelle, there had been a little bit of chat about the book that you had mentioned. I don't know if it was that colleague that's at UAB.
Yeah,
And then somebody had also requested if you would kindly pull open, I think your final slide.
I meant to ask if I didn't if I had the ability because I didn't want to cut off the
Yeah, no,
commentary and to like
I
distract
appreciate that.
people. Let me
But
share I'm going to share the final slide. And this is the official final slide that has email on it. So yeah, somebody
okay.
asked, I think, about the images. So
Yeah,
let's see, folks are paying, we're taking note of the visuals.
I can
And
hear
let me
the
get,
clicks going.
I'm getting the name of the book pulled open right here.
All right, thanks.
Do you want me to just put it in the chat? I don't know where.
I think it was you met the need. Thank you.
Yeah.
Thank you so much.
Uh, Dr. Patel, have you actually ever had a chance to work with a Hindu chaplain?
I have not, and I know there's a North American Hindu Chaplains Association where I know a lot of the folk, most of the people there are involved in sort of university chaplaincy. There are a handful of folks who I know are doing healthcare chaplaincy. I think I saw somebody had put up the certificate program that the Chinmaya Mission offers for anyone who's interested in becoming more versed in Hindu tradition, and I think those are all important efforts. I just know when you know, when you talk to folks within our community, at least even in my place of worship, most of them are telling their kids, chaplaincy is not on the list of careers that they're pursuing. So, um, to the detriment, obviously, to the good work everyone here does. And this is why I think long-term solution is going to have to involve, certainly doing the things of trying to train people in the profession, but also leveraging community support and figuring out how can we bridge patients and families with chaplains that work in the hospital and helping them understand their role.
That's great. They were both fantastic. It was great hearing your words. I'm going to just read out one of the questions though here.
Sure.
It has been my experience that those who identify with a non-Abrahamic religion often don't have their religious preference listed on their chart, thinking it might be irrelevant because they may be unaware of the diversity of chaplains and our wish to serve all identities. How might we increase patients identifying with a Dharmic religion?
That's a very good question. I will say, since having put all this together, and having talked to family members and friends and such, this is the only time where they've thought like, oh, maybe if I put my name of the tradition down, it might help somebody else doing similar efforts down the road. So I think a lot of times it's just not knowing why would anyone care about my religious tradition in the system. But I do think trying to use respect, like familiar communication outlets, like a place of worship, for instance, and trying to explain to them the importance of why it would be worth at least identifying yourself in the EMR for sort of the psychosocial considerations is an important first step.
And this for both either of you, it was in the chat here. Curious to hear your thoughts about the word chaplain itself in an alternative such as compassionate services, more relevant for those who practice NDR.
I don't have a good answer for this one. I can't, by the way, I'm down to one screen, so I can't see you if you were about to answer.
So you can actually close out your slide now if you like.
Okay, let me do that.
We can
So I
see
can
you.
see it.
See it better. There we go. Yeah.
Perfect. But I think what I was going to say was, I know, in that book that was laid out, like some of the earlier reports of Hindus, or what we know as Hinduism, came from missionaries with the British, were involved in colonial work. And so I definitely think there's a strong, when people hear the word chaplain, like there's a very strong association with Christianity that's invoked. As to what it would be rebranded as, I don't know if there's a clear alternative. I do think because spirituality is so mainstream now, it's probably the easiest one to kind of go to, but it's hard to know if, like, I think that's something that's Beck's point of question is, will people know what that actually entails?
Yeah. What about you, Yoon, Venerable Yoon? Because we talked about it, didn't we, offline at one point? There we go.
What's your questions? I'm reading the chart right now.
Oh, yeah, I was just asking about the word chaplain, if you would think it would be useful to have another word.
Oh, a spiritual care counselor?
Spiritual care counselor?
Yeah, I think that's a better.
Mm.
Yeah, actually, when we translate this English word to Chinese, yeah, we use a spiritual care counselor.
Ah.
Yeah, we can, yeah, I feel people, they more understand what is our services, not only limit to religious service.
Okay, we have a couple more questions here. Rushil, in light of issues about giving information about religious affiliation on admission, do you think the proportion of Dharmic religious patients in your study is underreported?
So that's a really good question. I will say that we were able to pick up a few more because there was a way to actually like look at anyone who had been visited by a chaplain in the system, and then they declared the religious identification. But I do think I don't think it's a dramatic, like a dramatically higher number, but I'm sure um, there are probably more than the ones that we were able to actually pick out.
Okay, great. Thank you. And there's one more quick question here. Can you speak more about the relationship between a lack of equity in the usage of chaplain services and unmet spiritual need? It sounded like sometimes spiritual needs in these populations are deeply personal and might not require outside support. What are the ways we can recognize when support is needed?
Yeah, that's a good question. And I think part of that is, just like and this is coming more from like the lens of sort of like palliative care, like when you have like cancer care navigators who tell people, all right, you have the cancer diagnosis, here's like the practical X, Y, and Z. I think at that time, if there could be some education to the families and patients' families about what are the different services that are available. Some of the interviews that I've been doing in Charlotte, that they have a robust offering of different services, uh, certainly palliative care doesn't always come up, and I know for a fact almost 0% know what a chaplain is, in the context of all the services that are available. So I do think that's something people know that these services are available and what help they can offer. At least the people who would be open to receiving external help could.
Yeah. Thank you. Did you want to say something, Yun, on that? Or I think we might have to wrap up in a minute. Is that right, Paul? How are we doing here on time? Yeah, I think we have to move on. There are some other great questions here coming in. But I can't hear you, Paul. Could you turn on your mic? Thanks.
Yeah, if you want to take one more, we have about a minute to go.
All right. I like that. Do patients of Dharmic religions access other, psycho-oncology resources? Yeah.
Yeah, I was gonna say the people who are plugged in with the faith group, some of these needs they're definitely leveraging that help. In certain organizations they have monks who kind of essentially effectively are functionally like clergy, and that they're answering some of these existential questions and things that folks are having. I know some people have tapped into the support groups. Again, it's sort of mixed depending on where folks are and they feel like they're around other people that have similar cultural experiences. And like I said, palliative care has sort of been on and off, at least in the study that we're doing right now in Charlotte, as to whether or not folks have used it. They usually use it's more for symptom management, less so the psychosocial piece of it.
Thank you.
Thank you. Brahman, thanks so much for convening this network, friends. If we'd love to have you join that cancer care, spiritual care research network within our community platform. You and Rushil, thanks so much for your generosity to be a part of us, sharing your wisdom and your insight, these findings. We look forward to future studies coming out of this space. And yeah, friends, check out Transforming Chaplaincy. Go to our website. We've got lots of other things happening. Another webinar happening in July. We appreciate your support. Thanks again, friends. Have a good afternoon.
Thank you so much.
Thank you.